Okay, guys, so today we're going to go over Module 26 in your Nield and Gehrig instrumentation book, and then we're also going to do Chapter 29 in the Darby and Walsh book, and these both are just going to go over power instrumentation, which is going to cover all of our ultrasonic scalars. Okay, so design and function. So today we're going to go over the types of powered devices, the strengths and limitations of powered devices, mode and mechanism of action, fundamental skills for powered instrumentation, and what kind of instrumentation strokes we're going to use. Powered instrumentation devices use rapidly vibrating irrigated working ends to dislodge calculus from the tooth surface, disrupt plaque biofilm, and flush out bacteria from the periodontal pocket. They usually consist of an ultrasonic generator, a handpiece, and interchangeable tips or inserts. Okay, so here's a photo of a powered instrument tip in action. I'm pretty sure that this is a piezoelectric scaler. We do have one of these in the clinic. At the end of this PowerPoint, I do have 2 YouTube videos, one going over ultrasonic instrumentation, or the Cavitron specifically, and then the piezoelectric scaler. The Cavitron one is going to be like 20 minutes, and it's going to talk about all the different tips. And then same thing with the piezo. That one's a little bit shorter though. It's only like 5 or 6 minutes. Just because for the most part in the clinic, we are going to be using the Cavitrons a lot more than we use the piezo. We have only one piezo where you guys each will have your own Cavitron units. I'll definitely say that in private practice, you're probably mostly going to see Cavitron units over the piezo, although I want you guys to be comfortable with both, just in case you end up in a private practice that does use only piezoelectric scalars. Okay. So it was around the late 1950s that they started developing the first electronically powered instruments, and then around the 60s, 70s, they were used to remove heavy calculus deposits, mostly supra. And then in the late 1980s, they developed slimmer working ends to where they could extend for subgingival calculus removal. Today, those powered working ends have been shown to be as effective as hand instruments for removing subgingival deposits, biofilms, and bacterial products. But does not mean that powered instrumentation is a standalone. You can't only use powered instrumentation. It's something that's used in conjunction with hand scaling, always, always, always. So it's going to be typically our first line of action that we kind of take around, remove large debris, also going to be used greatly for deplaquing. It's just a lot more effective time-wise. Okay, so we have our sonic powered devices, which operate at a lower frequency between 3 and 8,000 cycles per second. And then we have our ultrasonic powered devices, which operate at about 1,800 or 18,000 to 45,000 cycles per second. So under the ultrasonic powered devices, we have piezoelectric devices. You'll hear them called a piezo scaler. Then our magnetostrictive devices, which you'll hear those called magneto, or that's your Cavitron. Okay, so we have, this is just a diagram, powered instrumentation, how the ultrasonic scalars are going to include both the piezo and our magneto. So both the piezo and the Cavitron are both ultrasonic instruments. So piezo devices use electrical energy to activate crystals within the handpiece to vibrate the instrument tip. Magneto devices transfer those electrical energy to metal stacks made of nickel iron alloy to a ferrous rod to vibrate the insert. So this is important to know as far as like a board exam question. If there's anything that mentions crystals, that's going to be your piezo. And then anything that mentions metal stacks, that's going to be your magneto devices, or brand name for that is most commonly Cavitron. Okay. So our strengths of powered instrumentation, like I talked about, effectively removes supra and subcalculus deposits, effectively removes subgingival plaque biofilms. The slim tips can reach deeper into periodontal pockets than hand instruments can. Um, and basically you can just get better adaptation, especially in like furcation areas, to be able to do a working stroke, because this is always active, where when you have your hand instrumentation you're kind of limited. Like, yeah, you can get it in there, but you might not be able to get a working stroke engaged. The slim tips provide access to furcation areas, like I was saying, and then the water irrigation flushes out bacterial products from the pocket, where our hand instruments cannot do that. Then definitely instrumentation time reduced. So if you were to take, on a class 2 or 3, all the like even sub supra in the lower anteriors, it's going to take you a lot less time with the Cavitron than it would with your hand instruments, especially at the state that you guys are in with your hand instrumentation right now. Okay, so this is just a photo of an ultrasonic tip and getting to the base of the pocket and flushing all that bacteria out. Limitations. So, as with hand instrumentation, skill level of the clinician affects the outcome. Basically, how well are you adapting, and then are you using it properly? And then either piezo or magneto instrumentation is technique sensitive. So they both have a specific way that they're supposed to be used. And so it's important to use them in that way. And then with powered instrumentation, we do have less tactile sensitivity than we do with hand instrumentation. We just don't have, especially for fine root planing strokes at the end, that's where it's so important to bring in our hand instrumentation, where we can really feel and use our tactile sensitivity. And I really think that that's how a lot of stuff is missed, is people, a lot of hygienists kind of miss that hand instrumentation portion, and a lot of people are only using powered instruments, which is not effective. So mode of action is going to be very rapid vibrations of powered working end to create microfractures in the calculus deposits. It's basically just going to break it up and implode the calculus. It consists of a stream of water that's called the fluid lavage, and then the water dissipates the heat caused by the rapid vibration. So if we don't have enough water, then that's when our tip's going to get hot or even like warm. So it's important that we do have enough of like a water spray to keep that tip cool. Otherwise, especially if you're doing like root instrumentation, it's going to be really sensitive if it's too hot. And then water flushes the toxic products and bacteria from the pocket, like I had talked about. Okay, so our mechanisms of action, we have frequency, which is going to be a measure of how many times a powered working end vibrates per second. Then amplitude, which is how far the powered working end moves back and forth. So these are important definitions to know just for like board type questions. So this is going to be just remembering frequency is how many times we're getting vibrations. And then amplitude is how far the working end is moving back and forth. Okay, so frequency, compare the working end frequency to car windshield wipers. Low frequency, the wipers go back and forth a few times a minute. In high frequency, the wipers go back and forth many times in a minute. And then our stroke length or amplitude. So lower amplitude delivers a shorter, less powerful stroke. Higher amplitude delivers a stronger, more powerful stroke. So currently, there is no research that supports a difference between efficiency of high power and medium power instrumentation to maximize patient comfort and minimize potential to damage the tooth surface. The power setting should rarely be placed above medium power setting unless you're working like super gingivally and just like getting through really heavy, thick deposits. Then we want the higher amplitude. But like this says, what's most important for this is patient comfort, and we want to minimize potential damage to the tooth surface, because with powered instruments, we have to be really careful, especially with the root surface, because we know that just like hand instrumentation, you can overscale those root surfaces and remove the outer layer of cementum. And we want to try our best to preserve as much of that as we possibly can when we're doing subgingival instrumentation. Okay, so amplitude is like pushing a swing. Lower amplitude is like a low, you're barely moving back and forth. And then high amplitude is you're swinging really high and then all the way back and then really high, okay? So it's on a micro level, like you're really not going to be able to see the tip moving like that, but just understanding that that's what's happening is as you turn the amplitude up, that tip is moving a lot further back and forth. Okay, so cleaning efficiency is determined by the combination of frequency and amplitude. Low frequency, low amplitude, we're going to have fewer vibrations and shorter strokes. And this is ideal for removal of plaque biofilm. So especially like if you're seeing a child, we want to keep our frequency low and our amplitude low. High frequency and high amplitude is going to be many vibrations and longer strokes. And this is ideal for removal of tenacious calculus deposits. Or like I was talking when we have that really, really heavy even like supra that's really tough to get off. And we're kind of fighting through the thickness of it. Okay, so cleaning efficiency is determined by a number of vibrations and stroke length. So a boxer in a narrow box can exert a lot less force than a boxer in box B that has more room to move his arms back and forth, okay? So contraindications for powered instrumentation. So it's important to review the patient medical history and dental histories before using powered instrumentation, especially if your office has a really, really old Cavitron. So the older ultrasonic instrumentation devices were not shielded and could cause problems with pacemakers. But now the pacemakers are shielded, and typically so are our instruments. So that's not really a contraindication anymore. But if someone has respiratory problems, communicable disease transmission, so like if someone has active TB, right, we're not supposed to be working on them. Or this is a great one with like coronavirus. They talked a lot about reducing the amount of aerosols, because the Cavitron does, and the piezo scaler creates a lot of aerosol productions. So yeah, if someone has respiratory problems, we want to limit the amount that we're using this. Susceptibility to infection, and then cardiac implantable devices. That's what I was talking about, the pacemakers. We don't want to use this on sensitive or demineralized teeth, because the Cavitron can actually break through the demineralization. So if someone has generalized demin, we're not going to use the Cavitron. If they're really, really sensitive, they have like a lot of root exposure, and they tell you from the very beginning that they're sensitive, I would limit the amount of Cavitron usage. Now, if they had a pocket or an area that's bleeding a lot when I'm scaling, I might use it a little bit localized, but I probably wouldn't use it all over. Difficulty in swallowing. So this is something like if they've had a stroke and they can't swallow well, or they mention to you they have any problems with swallowing. Typically, like older people, when I worked at Holly Makua, most of my patients had strokes and had dysphagia, and so it was really, I didn't want to use the Cavitron on them, because basically it's a risk for them to aspirate the water. And then titanium implant surfaces, you need a special tip for, it's like a little plastic covering that goes over the tip to scale implants with powered instruments, okay? So it's important that we have the basic skills to be successful with power instrumentation. So our position is going to be the same as for hand instrumentation. Patient position is going to be also the same. It's a little bit easier if their head is turned to one side or the other so that the water can pool in the corner of their mouth. It's just easier for you to get it rather than having to like put your suction directly down the middle of their throat and gag them. Really important that we use a light, relaxed grasp with our powered instrumentation. We don't want to apply a lot of pressure because basically we want to let these tools work themselves and we're just gently guiding them around. We want to use extraoral, cross arch, opposite arch fulcrums as much as possible, though. We always want to use an intraoral fulcrum. Like I was talking with the pressure, we want to use really light pressure. Firm pressure actually decreases the effectiveness of the working end. And then we want to use the Explorer to evaluate deposit removal. So that's super important. As always, the last thing that we do is exploration, right? Because just like I was talking about earlier, our tactile sensitivity is a lot less with powered instruments. And you'll get to where you're more comfortable with this, especially with like the thinner tips where you can explore with your Cavitron tip. You just you can turn it off, take your foot off the foot pedal and deactivate it and kind of feel around. But especially at first, when you guys are still developing this tactile sensitivity, it's so important to make sure that if we're going after a big piece of calculus that we can see in the radiographs and that we're exploring, Cavitroning, and then exploring again to make sure that we get it. And then also using our hand instrumentation after so that we can smooth the surface completely. Okay, so calculus removal with a curette or a hand instrument, we're going to position it apical to the calculus, right? So we're going to get all the way underneath and try to channel it or remove, like basically flick it off. We want to get all the way underneath it and flick it off. We're going to start at the base of the pocket and work towards the CEJ. Calculus removal with a powered instrument is actually the opposite. We're going to work from the coronalmost region of the deposit. So we're going to start near the CEJ and work apically towards the base of the pocket, okay? This is super important, guys, and this will definitely be a board question talking about with powered instrumentation, do you, like which direction do you work? And the options will be, do you work from coronalmost region to base of the pocket or base of the pocket to the coronalmost region? So this is important to know. Also for your effectiveness, it's so important to know. And they talk about this a lot in the videos that I put at the end of the slideshow too. Okay, so here's a picture of just A is with a hand instrument. So we're starting at the base of the pocket and we're scaling up in a vertical direction. And with our powered instruments, we're going to work from the top where the green dot is. We're going to work like in a back and forth motion. It's going to be a quick back and forth motion all the way from the CEJ to the base of the pocket, okay? So piezo devices, only the working end needs to be cooled by water to prevent overheating. Our magneto devices are Cavitron handpieces, and the working end should be irrigated with water to prevent overheating. A common mistake is using not enough water. Then we have a warm working end, and this just indicates that we don't have enough water. And like I said, this is important for patient comfort and also for preserving the teeth, because you can cause damage if you're putting a hot tip on a root surface, okay, especially if it's activated. So the piezos, we're only going to change the very end tip, and the magneto devices are Cavitrons. We have both the magnetic stacks and the tip that we change between patients, and it's all connected together as one big piece. Okay, so water adjustment on the working end. So fluid reservoirs for powered instrumentation. So some units have independent fluid reservoirs, which is a bottle used to deliver the distilled water or other fluid solutions to the working end. So basically this is great, like when I worked at Holly Makua and I didn't have a dental, like an actual dental unit, having a Cavitron that all you need is a plug into the wall and it has its own water source is really nice. And you can also put chemotherapeutic agents in there. So using like Paradex in your Cavitron, like a cap full of Paradex in your Cavitron. Not a lot of support on whether or not that's effective to enhance pocket depth reduction. Like in comparison to just using water, there's no like research that supports it. Some hygienists though, they love to use Paradex in while they're using the ultrasonic instrumentations, and that's great too. That's kind of a personal preference thing. Personally, I don't do that just because if you have a fluid reservoir, it's important that you change it often, and so it's hard to know, or like if it's a big fluid reservoir, you have to like just sometimes waste it, dump it out. If it's too small of a reservoir, then you're filling it up all the time. And usually that's what the problem is that it's too small of a fluid reservoir and you got to fill it up like 5 times a day and it's just a pain. But again, great for settings where there's no water hookup. But ours in the clinic will not use fluid reservoirs. They'll just plug directly into your unit and use the water source from your unit. Okay, so here's a picture. This is a piezoelectric scaler here, and it has its own water reservoir. Okay, instrumentation strokes with the ultrasonic instrument. So strokes for calculus removal. Powered working ends break up the calculus deposits with microfractures. Like I said, kind of implodes it. Common misconception is that the powered instrument is like a magic wand using a quick swipe of the working end to remove deposit. The correct technique requires slow, repetitive strokes to accomplish calculus removal. This is like the most common thing that I see is like, I remember when I had students last year, I'd be like, okay, let's go ahead and there's a little bit of calculus that you missed on this one spot. And instead of picking up their Explorer to feel it, a lot of them would just like straight grab the Cavitron and just like put it in there, like wave it like it was a magic wand. And then again, never pick up the Explorer and say, okay, I think I got it. Like, no, this is so, so important that we're using our exploration and not just, oh, you missed calculus, just put your Cavitron in there and it's a magic wand and it will remove it. Okay. It's something that you have to know where the calculus is to properly position your Cavitron to get it, or ultrasonic of any kind if it's a piezo. So really important that we're not treating these power instruments like they're a magic wand. Okay, so again, only gentle pressure is needed during power instrumentation. Firm pressure is going to reduce our effectiveness, okay? Slower, repetitive strokes are more effective in removing tenacious calculus. We want to use an overlapping vertical or oblique strokes, okay? Those are going to be our most effective. Mechanical removal of plaque biofilm is needed. Periodontal health cannot be achieved without removal or disruption of the established biofilm. We've got to be able to disrupt that layer of bacteria so that we can get tissue healing. Ultrasonic instrumentation under low pressure can accomplish deplaquing. Use methodical overlapping strokes that are close together and effectively removing biofilm. And the working end should always be kept moving, okay? And that's just for patient comfort and to be the most effective. We don't want to just set it on top of a piece and not move it. It's always got to be moving. We're going to use a series of gentle sweeping motions over the root surface to remove plaque biofilm. Short strokes should cover every millimeter of the root surface using strokes in vertical or oblique or horizontal directions. Normal sulci in the absence of inflammation are likely colonized by beneficial bacteria and don't need to be deplaqued. Which, how many people are you going to see with normal sulci with no inflammation, right? It's going to be really rare. It's like on each other, right? So this is just a picture of, this looks like a piezo tip underneath the tissue. And you're just going to use that sweeping motion, keeping your tip adapted though, the same way that we keep our tip of any other instrument that we use adapted to the tooth, okay? So for successful outcomes, clinicians should apply fundamental skills of instrumentation when using powered instrumentation devices. Modern, slim working tips allow access to deep pockets, bifurcation areas. They use interchangeable inserts to remove supra and sub deposits. They're great in disrupting plaque biofilm and flushing out toxic bacteria and product from the pockets. They use gentle pressure with overlapping strokes to remove deposits. Okay, so powered working and design. So we're going to talk about tip design and selection, sequence for use, use on dental implants, instrument tip wear, tip adaptation and orientation, and instrumentation challenges. So a wide variety of instrumentation tips design are available. There's two basic types of powered tips. So we have a standard tip, which is going to be larger in size with a shorter shank. And then we have our slim perio tips, which is going to be about 40% smaller with longer, more complex shanks. So just like our hand instruments, we have ones that are going to be larger, and then we have our thinner ones. Okay. Powered tips vary in size, length, and shape and curvature. Tip selection is based on what kind of calculus we have. Are they small? Are they large? Are they tenacious? Are they on the root surface? Are they on the enamel? Are they subgingival? Are they supragingival? Do we have multiple different kinds? Do we have calculus imbrications? And ultimately, this is going to be a lot like our hand instruments, where sometimes, like, there are some hygienists who love Gracies and there are some hygienists who love universals. You guys are all going to kind of develop your own preferences on what kind of tips you like. So our standard tips, this is a piezo tip, but standard tips are going to be shorter shanks, and these are going to be used for heavy deposits, typically supra, and then we want these to be used in areas where we're not going to disrupt the tissue, okay? So because these are big, they're thick, they're a little bit more aggressive, we want to use them where we can see them. If we're using these subgingivally on like really high power settings, and even if our patient's numb, it's important that we're not causing trauma to the root surface. So understanding standard tips are going to be used for heavier deposit removal and supragingivally for the most part, okay? And then our slim perio tip, again, this is a piezo tip example over here on the left, but these ones are the ones that are going to be about 40% smaller in size. We're going to have longer shank lengths. This is going to be light to moderate deposits and deplaquing, instrumentation of root concavities and furcation areas. So usually we're going to use more than one tip, because usually people are going to have more than one type of calculus throughout their mouth, okay? So we're going to use our standard tips first, followed by our slim perio tips. Clinicians should consider a cross-section of the tip. So rectangular or beveled in cross-section are effective in calculus removal. Round in cross-section is effective for deplaquing. So our standard tips, like we said, going to remove moderate to heavy deposits above the gingival margin and in shallow pockets. Slim perio tips are going to be used light to moderate calculus deposits on anterior teeth and posterior root surfaces. Round tips are going to be used for removing biofilm and light calculus deposits. The flat lateral surfaces are going to remove medium to large size deposits. So sometimes, guys, you're going to have, 3 to 4 tips out for one root planing patient, and it's just so that you can get a tip that adapts to every area that you are cleaning. Instruments used for the assessment and debridement of implant teeth should be made of materials softer than titanium. So tips coated with non-metallic plastic or carbon material are appropriate for instrumentation of dental implants. Metal instruments may scratch the titanium implant surfaces. So like I said, they make these like little yellow plastic tips that just go on the end of like your Cavitron tip. And that's what you'll use around the dental implants. Okay, so this one is a plastic for the piezo, just like a little plastic insert that you can use and just flush around the implant. Okay, so it's important that we inspect our power instrumentation tips regularly. With use, the tip is worn down and less effective. A rule of thumb, 1 millimeter of wear results in approximately 25% less efficiency. A tip with 2 millimeters of wear should be discarded. So this is a piezo tip also, but most times, like when you order tips, or we have one like on the autoclave that you can like put the tip up against the little measuring thing and it will tell you when it's time to get rid of it. So this is just showing the piezo tip, 1 millimeter of wear is 25% efficiency, and that just like the tip just wears down as you use it. It's not like you're not taking care of it. It just, as you use it, the tip wears down. Same thing as like when you're sharpening your instruments, the tips get a little thinner. Okay. So we want to adapt the appropriate tip surface to the tooth surface to control energy dispersion. We never want to use the direct point of a powered instrument directly on the tooth surface. So important. That will be a board question. It will be a question on your exams. We never ever use the point of a powered instrument. So the very tip we don't use on the tooth surface. You can use all other sides. We want to adapt the lateral surfaces of a piezo tip for removal of calculus and plaque biofilm, okay? So this is just showing the point, the back. We also know we have lateral sides here. And this is showing the tip directly on a tooth surface. We don't want to do that. It's going to send your patient through the roof. It's really uncomfortable, and that's what causes damage to the tooth surface, okay? It's our most active point on our powered instrument, or the point is the most active place on a powered instrument. Okay, so this is a piezo tip again. You're going to use the lateral surfaces. A piezo tip is really similar to our hand instruments, where we're going to use the lateral surfaces, okay? Okay, so lateral surfaces of a power tip are the most effective for calculus removal. With hand instrumentation, the cutting edges are used to remove the calculus. But our active tip area is going to be the portion of the instrument tip capable of doing the work, which is the last 2 to 4 millimeters of the lateral surfaces. So same thing as our hand instrumentation, guys. We want to use like the end 2 to 4 millimeters of our lateral surfaces for our calculus removal, okay? Okay, so this is just showing our area of the active tip, and we never want to use the point. And then basically just showing you against a universal curette where the active areas are, okay? Orientation of a powered tip to the tooth surface. So we want to use transverse tip orientation. The tip is going to be positioned to the lateral surface in a transverse or crosswise orientation to the long axis of the tooth. So here's a picture of that. We just want to stay adapted and see they're going to start at the coronal-most portion of the calculus deposit and work their way down to the base of the pocket, okay? Vertical tip orientation is going to be, the tip is positioned with the lateral surface against the tooth in a similar manner to a universal curette in a toe down position. So a picture of that is as you do the mesial surface. So the transverse tip, they're doing like the distal portion, okay? Where when we have the vertical tip orientation, that's when we're going to do the mesial and the buccal, or I mean the buccal and the mesial, Okay, again, they're starting at the most coronal portion and working their way apically. Okay, so transverse orientation removes calculus from coronal surface and is used for subgingival deposits slightly below the gingival margin. Universal tips can be used on all tooth surfaces in the transverse orientation. Curved tips come in right and left styles, and both tips are needed to complete the dentition. And I'll show you guys these when we do our, you're going to see it in the YouTube video I posted at the end of this, but also when we have our ultrasonic clinic on the 24th, then I'm going to show you guys all this stuff. We're going to do it in real time before you do it on each other. The curved tips are used in a transverse orientation to remove deposits from the proximal surfaces of posterior teeth. So this picture here, this is a curved tip, okay? So transverse orientation for the standard tip, just showing you, again, working coronal-most portion apically, okay? The right or left curved piezo tip does not refer to where you use the tip in the mouth. Right or left refers to the direction of the curvature of the instrument tip itself, okay? So again, I'm going to show you guys these and it will just make a lot more sense when you see it in action. And like I said in the YouTube video that I posted in this, they also show the curved tips. Some people loved the curved tips. Like I know Miss Larson, she really likes the curved tips. I'm not a huge curved tip person just because the way that I sequence, especially if I'm doing like upper right, lower right, like half mouth approach on a root planing, I feel like I have to change the tip the whole time, like I'm always going back and forth. So I prefer to use more of a universal tip, but again, everyone's going to have kind of their preference of what they feel like adapts best. And it's going to be different with each patient too. So this is a picture of the right and left curves, and you guys are going to get practice with doing this, but the one on the left you would use for the lower right buccal and the upper right lingual. And then the one on the right you would use for the upper right buccal, lower right lingual, okay? And you guys will get practice with adaptation of these and you'll get more comfortable, and you'll be surprised that now that you know how to find the correct working end with all of your instruments, it's going to be really easy to find and adapt the correct working end with ultrasonic instruments. Okay, so we want to complete all the surfaces with our right curved before we switch to the left curve. So like I said, you'd want to do all those surfaces. But I prefer to like complete the upper and then complete the lower when I'm doing the Cavitron, because usually the lower takes a little bit longer to get all the way numb. So I like to start on the upper first while the lower is getting numb. And like I said, that's my personal preference. Not everyone's going to feel that way. Some of you guys will love the curved tips, and that's awesome, but it's just for efficiency. Like if you were just doing a prophy and you wanted to use the curved tips, you'd want to do all the surfaces that you would use with the right curved and then all the surfaces you'd use with the left curved, okay? So here's our transverse orientation on the facial aspect. Okay, transverse orientation on the lingual aspect. And then vertical orientation of a powered slim tip is used for periodontal pockets. For calculus removal and deplaquing. So straight slim tip in a vertical orientation. So this is just showing our adaptation here. Again, these are all the examples they're showing right now are piezo tips. But I'll show you guys these with our Cavitron tips too, okay? A straight slim tip in the vertical orientation on a posterior area. So in the vertical orientation, the curved tips come, like I said, right and left. Both tips are needed to complete the dentition. Curved tips are usually are used in a vertical orientation to instrument root concavities, convexities, and furcation areas. Basically, deeper pockets are where we're going to use this vertical orientation. For efficiency, we want to complete all the surfaces using the right and then switch to the left, just like we talked about. And that's so that you're not doing the switching back and forth of the tips the whole time. Okay, instrumentation challenges. Removing stubborn calculus deposits. So, biggest thing, we need adequate time. We can't just wave our ultrasonic instrument subgingival and be like, okay, it's gone. A single quick stroke with a powered instrument will not completely remove deposits. We have to select the proper tip for the task and one that can be used with a medium power, especially if it's subgingival. We want to maintain proper control and adaptation and use a combination of strokes in different directions with the correct tip. So a lot of times you're going to be using like horizontal strokes, and then you'll be using oblique strokes and then vertical strokes. It's going to be a combination in order to go over the calculus in all directions to get all the layers off too. You may need to change to a different tip. Begin with a hand-activated periodontal file. We're going to talk about files a little bit later. Especially with your more difficult patients, there are some times when a periodontal file can be great. Those basically just fracture up tenacious deposits, or they help to get burnished deposits off. But like I said, we're going to go over periodontal files later. Then also, you may need to increase the power setting to get those stubborn calculus deposits off. There are specialized powered tips that you can use to recontour a defective margin or an overhang. And that smooth surface is going to basically just be easier for the patient to clean and deter bacterial accumulation. So this is an example of that, the Hu-Friedy diamond tip. If I'm being super honest with you, I don't feel 110% confident with this. And I'm really spoiled that I work for a doctor that doesn't create a boatload of overhangs, because I don't know, I just contour, and even I went to school I did restorative hygiene, so I know how to place fillings and how to use interproximal smoothing strips and all that stuff, and I still don't feel 100% confident using this diamond tip, just because you can create a lot of root damage with it. So it's important that you only use it on the overhang. I think we do have a couple of these in the clinic. And like I said, we're going to go over how to use all of these things on our ultrasonic clinic day, okay? So here's an amalgam overhang, and you can just take that diamond tip on it and smooth it so that it creates a more properly contoured area, okay? Okay, so instrumenting in furcation areas, like we talked about, that slim perio tip, that's going to be the most effective way for treating furcation areas. Powered tips with a ball tip are used in furcation areas to provide gentle and thorough debridement. Deactivating the powered tip until the entrance into the furcation is detected with the tip. So basically, you insert your instrument before activating it, so that you know where you're at, because like I said, your tactile sensitivity is going to be a lot less, especially when the tip is activated. So we kind of explore our way into the furcation and then activate our tip. Turn the tip to access the roof of the furcation. Here's a picture of the ball-ended slim furcation tip. Okay, and the ball is just going to help you so that when you're deep in a furcation, you're not accidentally using the point, okay? Because remember, the point can cause root damage, and so we want to avoid that at all costs. So it's just a picture. Once the ball-ended tip accesses the roof of the furcation, the ball end is rolled back and forth across the entire roof area, okay? Getting in there and cleaning it out. Okay, so a little recap. Ultrasonic devices offer a variety of tips. We have standard, slim, and curved to effectively remove calculus deposits and deplaque periodontal pockets. Clinicians need to be familiar with the sequence for use of powered tips with the proper orientation of tips to the tooth surface for effective debridement. Instrumentation challenges such as stubborn calculus deposits or furcation areas require alternate strategies by the clinician to be effective at removing calculus. Okay. Okay, treatment preparation and setup. Okay, so aerosol production and containment. This is where it's really important, guys, especially right now. The big topic is ultrasonics create too much aerosols, but ultimately it's the best way to treat our patients, especially our perio patients. So how can we minimize the aerosols? And then talking to your patient and you being prepared as well. So, oops. Aerosols are airborne particles that compose of debris, microorganisms, and blood propelled into the air from patient oral cavities. Aerosols can remain suspended in the air for many hours, meaning it's something that between patients, your morning patient could pick something up from your afternoon patient if you're not managing your aerosols correctly. Ultrasonic instruments, dental handpieces, air polishers are the greatest producers of aerosol contamination. Bacterial aerosols are important consideration for infection control. Also, viral aerosols are important for infection control. Microorganisms of the mouth and respiratory tract can be transported into aerosols and can contaminate skin and mucous membranes of patients and dental personnel. They say airborne and float in the office air, currents moving some distance from the point of origin. Risk of contamination continues long after the procedure is over. So, during treatment, evacuator tips should be used to reduce airborne contamination. A saliva ejector is not an effective means of controlling aerosols. So, we need to use like our HVE, those new mirror suctions. That's what those are for, is for containing our aerosols. So we use that with our hand pieces when we're polishing. And then always, always, always with the, when we air polish, we're going to use the HIVAC, and then any ultrasonic instrumentation, we're going to use the HIVAC also. Okay. Also, explaining to your patients the powered instrumentation. So a pre-procedural rinse is recommended to reduce bacterial load and aerosols. Typically, the pre-procedural rinse that we use is Paradex. Right now, the pre-procedural rinse should contain hydrogen peroxide just because of that's what the American Dental Association is recommending for reduction of aerosols with the coronavirus. And then PPE for the patient, plastic disposable drape, protective eyewear, applying non-petroleum product to the patient lips. So we do not have these in the clinic. Honestly, I've never, ever seen these used. This PowerPoint was the first time I've ever seen them, but they do make these for patients so that, but this is interesting to me because I'm like, it's their own aerosols, right? So it's not like it's gonna get them sick. It's like if you had aerosols left over, but a high volume evacuation suction is going to reduce like 98% of the aerosols that you create. So, but these do exist. Good to know. So it's important that we wear a gown, with sleeves, a mask, protective eyewear, and gloves. A face shield is great. And then using high bacterial for filtration efficiency mask for powered instrumentation procedures. And then changing your mask every 20 minutes is the recommendation. And that's if you were cavitroning for more than 20 minutes, basically. Because it will soak your mask really quickly. But if you're wearing a shield, then your mask is not going to get soiled as quickly. Okay, so little recap here. We talked about we want to manage our aerosols for both the patient you're working on, each other's patients, and then the patients the rest of the day, plus all of us, right? That's how we stay safe. And then during treatment, we should be using high volume evacuation to reduce our aerosols. Both the patient and clinician should be provided with PPE, following specific manufacturer instructions, proper setup, and cleanup steps when preparing a power instrumentation unit. Okay, design and function. Okay, so this is our piezo unit setup. Okay, so we're gonna connect our fluid reservoir, dry the handpiece, dry the cord, put them together. attach your piezo tip. This is all in the YouTube video that I put in the end also. Turn on the unit, select appropriate power, remove the wrench. This just helps you when you're putting the tip on and taking it off so that you don't poke yourself, okay? And then we want to set our irrigation flow rate depending on which tip we chose. Get our foot pedal ready. And then we're going to always check the irrigation spray like in our sink before we start, okay? End of treatment, we're going to take the tip off. We're going to clean the very end of the tip. Put our wrench on and remove the tip from the handpiece, and then prepare the equipment for sterilization. The piezo ones are usually done like in a cassette, but we just bag our Cavitron tips. Okay. We already talked about that. Oh, okay. Here's our YouTube videos. The top one is going to be the Cavitron one. Bottom one is going to be piezo. Okay. So now we're going to move to chapter 29. Okay. Ultrasonic instrumentation. Okay, so this one again is from the Darby and Walsh book. So basically for this, we're going to talk about what's the difference between magneto and piezo instrument, like how they move. Okay. And we want to discuss technique and tip design again. So again, our objectives for periodontal debridement, we want to remove the calculus and the biofilm. We want to move any plaque retentive factors, so that's like overhangs. Calculus is technically a plaque retentive factor. And then again, we want to conserve the tooth structure, and we want to obtain resolution of inflammation. So we have our mechanisms of action. So we have mechanical is primarily action. Irrigation is usually water. It's used with ultrasonic instruments to counteract any frictional heat generated by the oscillating tip moving against the tooth surface. The cavitation is going to be the explosive collapse of microscopic bubbles and a flowing liquid resulting from forces acting on the liquid. And then, okay, I think that was it for that one. Okay, so for our magneto devices, we have the insert, a handpiece, a base unit, and a foot switch. Our piezoelectric devices have a tip, handpiece, base unit, and a foot switch. So basically the difference here is the insert and the tip. Like I said, the magneto, we're going to take out the entire ultrasonic or the Cavitron insert, which has the magnetostrictive strips and the tip, where the piezo, the tip just comes out by itself. Okay. So ultrasonic scalers are, there's operational variables. So we have our frequency, power input, water flow rate, and then tip diameter and shape is basically going to understand why we're using each. Okay. These are some pictures of some, our last PowerPoint had piezo tips, and on this one I put Cavitron tips, or magneto strips. So this one here is our standard, the blue tips. They're going to have a greater mass, circular or rectangular in cross section. And these are going to be used, like I said, sub and supra, but some of the blue tips will be used only supra depending on their cross section. Going to be used on higher frequency with more water. The slim tips are going to be less mass, reduced in diameter, circular or rectangular in cross section. And then our ultra slim are going to have the least amount of mass, narrowest in diameter. And these ones are going to be circular and straight in geometry. So the purple tips are typically what we're going to use subgingivally, and like these ones are great for people who have like really tight lower anteriors, infurcations or really deep pockets. Your green tips are going to be like your everyday prophy tips. Like you'll also use them in root planing. Like this is going to be probably your most often used. And then the blue tips are going to be more like when you have someone who hasn't been in a really long time, someone with really heavy stain. These are awesome. Ultrasonic instrumentation is great for the removal of stain also. Okay, so function is produced by an ultrasonic scaler. We have efficiency of mechanical mechanism of action, amount of cavitation, and microstreaming activity. We want to have an appropriate level of acoustic power. So displacement of amplitude, and then we have our tip diameter and shape. So like I said, super important for our tip selection, and that we're able to properly adapt those things. This is kind of just review from the last PowerPoint also. So is this one. But I wanted to talk a little bit about the difference. This is, yeah, all the same as the last. The difference in our magnetostrictive and piezo devices. And it's the way that they move. So I'm just going to add this in here too. This one has elliptical movement. And this one is linear movement. Okay, so our Cavitron is going to move the tip on a, like if you looked at it under a microscope, it's going to make an elliptical movement, okay? So like almost like an infinity sign, okay? That's microscopically what it looks like. Now, a piezoelectric is going to make linear, just a back and forth, okay? So here's pros and cons of that. The piezo, it is a little bit easier for our minds to grasp a linear movement because that's what we're using with our hand instrumentation, right? We're using mostly linear strokes. We're not moving it in an elliptical manner because that would be like impossible with our hand instruments. So typically like in perio offices, you will see more piezo devices. It's just what's most popular in perio offices. And it's because they do say hygienists are more effective with a piezo because of the way we're taught our hand instruments. Now, what's interesting about that is most offices on like a grand scale, which is why we have so many Cavitrons at the clinic, magnetostrictive devices are the most common, most commonly used, and it's because that's what we get used to, just because that's what everybody already uses. And so I would say, like I said, I want you guys to be comfortable with both, but what's most widely used is the magnetostrictive or the Cavitron, okay? So just knowing that, that's like a board type question. What shape does it make microscopically? Knowing that magnetostrictive is elliptical and piezoelectric is linear, okay? So please make sure that at the end of module 26, this PowerPoint here, that you guys watch these 2 YouTube videos. This lecture is supposed to be like 2 hours, so that's kind of what, or hour 45 with your guys' built-in breaks. So these 2 YouTube videos plus this lecture today will equal this. We're gonna do like a big review of all of this for our with our ultrasonic clinic on the 24th. So if there's things that you don't understand, don't stress. It's going to make a lot more sense once we get it set up and I'll do a demo, and then we'll work on our partners, and you guys will have time for one-on-one instruction, and you'll feel very comfortable doing this. I promise you it's very easy to learn how to adapt a powered instrument tip once you've already learned how to adapt all of your other instruments. So I'm super excited that we are going to be getting started with using our Cavitrons, and I think it's going to make your guys' lives easier. I just want you to understand that it's so important that you're using a combination of powered instruments and hand instruments. I want you to be strong hand scalers, just because at the end of the day, there could be days when your Cavitron's broken and your doctor has to send it in to get it fixed for 2 weeks. And you can't just say, oh, I'm not going to work until it's fixed. So we want to be strong hand scalers, and also understanding when it's appropriate to use. If you have a class 1 and doesn't have a lot of plaque, doesn't have a lot of bleeding, is it really indicated for you to use a powered instrument on that patient? Probably not. Now, if you wanted to use it locally, like I said, maybe they have a little bit more buildup in the lower anterior upper molars, you want to use it there. But kind of getting down the efficiency of when it's appropriate to use a Cavitron, stuff I want you guys to talk to your instructors about, like, hey, I'm thinking of using the Cavitron on this person, or, instructors may be saying, no, this would be a great patient for you to hand scale just for efficiency. So starting to kind of set time goals for yourselves, and that way you guys feel more comfortable towards when we get toward the end of your clinicals and you're like, okay, I can go to hour appointments, hour and a half root planing appointments. I'm going to be able to be efficient with my instruments. And that's what's really important for me to see you guys doing. So we're going to be working on this for the next, year and a half before you guys graduate, perfecting our sequencing and just use of our instrumentation. So these 2 YouTube videos I'm going to have you guys watch so that it will be easier for us to go through all the tips. You'll have already heard it once or twice by the time we do our clinic. So I will see you guys soon.